Welcome, everyone. We're going to get started in 1 minute. It's great to see so many names on the line. We will get started in 1 minute. Thank you. I think we'll get started. I want to welcome you to our first Emerging Practice webinar on behalf of the Regional GBV Working Group for East and Southern Africa. My name is Jessica Gorham, and I'm the Regional Emergency GBV Advisor based here in Nairobi, covering East and Southern Africa. And I work on behalf of the GBV AOR, which is the Global Coordination Mechanism for Gender-Based Violence in Emergencies. I'm really pleased that for our first event this year that we're co-hosting this webinar with the Food Security and Nutrition Working Group. And I see that we have both of their chairs joining us today. We have Brenda Lazarus, who is the co-chair of the working group from FAO, and also Charity Sami from IGAD. And in just a couple of minutes, we'll have a few words from Brenda. Before I hand over to Brenda for just a couple of words, I would like us to go over a few ground rules. Those who have attended our Emerging Practice webinar series in the past, these are probably be familiar, but I'll just remind everyone. If you could please keep your mics on silent or mute throughout the presentations. And also, we will not be using our videos today. We have lots of people, as you can see in the chat, we have lots of people joining us from countries throughout the region that might not have the best internet connections. And so if we all take ourselves off of video, it will give them a better chance to have a steadier connection. So if we could, and you might see some of my colleagues as well throughout, taking you off video so that we don't have an overload. So those are the ground rules. Please keep yourselves on mute and then also off video. In terms of questions, the way that our way of working here at the Regional GBV Working Group, if you could please put your questions in the chat. And my colleagues and I'm joined by Christine Appio, who is the co-chair of the risk mitigation pillar of the Regional GBV Working Group. So she will be supporting me, and then also Christine Cabelli. So please feel free to write your question in the chat. We will be monitoring the chat throughout the presentations so that you can really just focus on listening. We will be monitoring the chat throughout the presentations and then grouping like questions together. And then we will ask the appropriate speakers at the end. And we might have some ability to ask questions in between too, depending on the flow of the presentations. So please, if you do have questions, please write them in the chat, and then we will monitor the chat, put like questions together, and present them to our speakers during a Q&A at the end. So please keep that in mind. And then also we're going to keep our mics on mute and then no videos as well. Before I hand it over to my colleagues at UNICEF and ACF, I would like to maybe, if Brenda, I see that you're online from the Food Security Nutrition Working Group, who, as I mentioned, we're really excited that we're co-hosting this today with them. If you'd like to just say a few words of introduction, we would appreciate it. Over to you, Brenda. All you have to do is unmute yourself.
Great, thank you. Are you able to hear me?
We hear you well.
Okay, great. So good morning, everyone. So as Jessica said, my name is Brenda Lazarus, and I am an economist with FAO's Sub-Regional Office for Eastern Africa based in Nairobi. I also co-lead, as was said, along with EGAD, the Regional Food Security and Nutrition Working Group. From FSNWG's standpoint, we are very excited to be co-hosting this event today and to help advance the conversation relating to GBV risk mitigation in both nutrition as well as food security programming in the East Africa region. Furthermore, over the past year or so, FSNWG has been pushing to really strengthen the collaboration between the various humanitarian sectors, including between the food security, nutrition, and GBV sectors. So far, I think we have had several successes on this front, including the inclusion of GBV issues in FSNWG monthly briefings on the current drought situation across the Horn of Africa, as well as collaborations in developing linked food security and GBV early warning systems, and work to incorporate gender and GBV into the integrated food security phase classification, or IPC methodology. With that said, I think we are very much at the beginning of these collaborations, and I'm really looking forward to both the webinar today, as well as kind of further conversations and collaborations in the months to come. I don't want to take up any additional time because I know that we have a lot of interesting presentations coming up today. So I will stop there, but like I said, thank you again for participating, and we're really looking forward to the event. Thanks, and I'll pass back over to Jessica.
Thanks, Brenda. Those words are appreciated, and we do hope that this is the beginning of a long engagement in terms of coordination. So thank you both, Brenda and Charity, who are the co-chairs of the Food Security and Nutrition Working Group. So on behalf of the Regional GBV Working Group for East and Southern Africa, I'm going to turn it over to our member organization, which is UNICEF. We have our colleague Sinead Murray on the line. Sinead, I'm going to turn it over to you, and you can introduce also your colleagues and I think the co-leads on the study from ACF as well. So I will turn it over to Sinead, who is one of our member organizations of the Regional GBV Working Group. And as I mentioned, please do write any questions that you might have for the participants throughout the presentations in the chat, and our team here will be monitoring it and marking those down so that we can pose them to the speakers at a later date, or at a later time. Yeah. Okay. So Sinead, over to you.
Thanks so much, Jessica. Can you confirm that you can hear me okay?
We can hear you well, Sinead.
Wonderful. Thank you and good morning, everyone. We're really excited with this opportunity to share some of the learnings on our GBV nutrition work in South Sudan. My name is Sinead Murray. I'm the GBV and Emergency Specialist with UNICEF at the regional office in Nairobi, and I'm joined by some colleagues from our nutrition team and from Action Against Hunger. Over to you, Marjorie, for your introduction. Thank you.
All right. Good morning, colleagues. I'm super excited to be part of this webinar and to showcase the collaboration between nutrition and GBV. My name is Marjorie Volege. I'm a nutrition specialist with UNICEF based at the regional office, and will be co-facilitating and supporting the workshop today. Thanks, and over to you, Sinead.
Thanks. Tessa, do you want to come in and introduce yourself now?
Thank you, Sinead. Good morning, colleagues. My name is Tasfazion Waldazadik. I work for Action Against Hunger as a regional nutrition and health specialist for regional office in Nairobi. Thank you. Over to you, Sinead.
Thank you. And finally to Martin for your introduction. Thanks.
Hello, good morning, everyone. My name is Martin Kome. I'm the Regional Nutrition and Health Manager working for Action Against Hunger in the Horn and Eastern Africa Regional Office. I'll be co-facilitating this webinar, and happy and proud to see everyone here. Thank you. Over, Sinead.
Thanks, Martin. And again, welcome everyone. We're really excited with this opportunity to share our learnings from the GBV risk mitigation and nutrition work in South Sudan. We're going to start with Marjorie's going to provide a little bit of an overview and a background to the GBV nutrition webinar. Thank you.
All right, thanks so much, Sinead. So just to highlight for the GBV and nutrition work in South Sudan, this is made possible with the collaboration from the Ministry of Health in South Sudan. We have Action Against Hunger, UNICEF, as well as we have the Kenyatta University that are leading the research at the country. Now, we have 3 main objectives for the webinar today. And the first objective for us is just to provide an overview of GBV nutrition collaboration in South Sudan. So this is the work that has been ongoing for the past 2 years, and we have made a significant milestone and learning that we hope that we'll be able to showcase and hopefully share some of the highlights and findings from the study, and we look at in terms of integrating that in other programmings. So the third objective that we'll be looking at is just to look at the GBV risk mitigation programming, and this is based from the learning that we had. So as part of the learning, as part of the engagement, we have identified some of the key programming actions, some of the interventions that needs to be collectively delivered, both by the GBV cluster as well as the nutrition cluster. And you look at in terms of also looking at more in terms of the longer term, but also in terms of the shorter term. This hopefully will help in terms of feeding the next phase of the study, but noting that this is a webinar that encompasses all other regions and other country offices as well. We are hoping that we can get some of the learnings from the webinar and be able to integrate it within the programming, but also be able to scale up some of the learnings across board. Thanks, and over to you, Sinead.
Thanks, Marjorie, for that introduction, and I hope everyone's excited about this. Just by way of flow, I'm going to start by providing a bit of an overview of some of the learnings from a rapid evidence assessment that we carried out recently that looks at the linkages between GBV and nutrition outcomes. I'll then pass over to Tesfa and to Martin to delve a little bit deeper into the GBV nutrition research in South Sudan. And then we'll provide an overview of the GBV nutrition programmatic package. And then Marjorie will talk us through some of the next steps. So I guess, one of the big questions is, why is GBV relevant to nutrition programming? And there's so many linkages between exposure to GBV and nutrition outcomes. And we're still really learning more about these. And this research is really important in adding to the evidence base on this. And we're also learning more about the opportunities we have as GBV and nutrition actors to really come together to address some of these issues. But at the most fundamental level, we know that women and girls are the main users of nutrition services, and that in most communities, there's a lot of value and trust placed on nutrition services. They're often a good entry point for survivors to seek support, and in many of the locations where we're working, there's often no dedicated GBV services. So women or nutrition services may be the first place where women and girls who are experiencing violence may disclose and seek help and ask for referrals to more specialized actors. And, through this research, we're really starting to build our understanding that we can make nutrition services much more safer and accessible. Then it will have positive impacts both on the uptake of GBV services, but also on nutrition programming and nutrition outcomes themselves. There's lots and lots of other linkages between GBV and nutrition. We know that withholding food is based on gender is a form of GBV that girls often experience. In the household level, gender inequalities and a lack of power and decision-making in the home can really limit the effectiveness of nutrition interventions and the uptake of services, as many women and girls may not just be permitted to access these services by their husbands. Also, in times of food insecurity and when there's a lack of food, and basic resources. Many women and girls are forced to engage in harmful coping mechanisms, and sexual exploitation and abuse often becomes more common. Within our program design and delivery, we know that the location and even the timing of nutrition services and where facilities are situated can either increase GBV risks on the way to the facilities, or even, if the timing isn't well thought through, women can experience more violence whenever they go home if they're taking a longer time. Also, the community's understanding of nutrition programming and the criteria can also deter or permit access to nutrition services. So, there's so many opportunities for collaboration. And, one of the ones that we're really looking at is how to promote better two-way referrals between nutrition services and GBV programs so that we increase the utilization of both services. Last year, we carried out a rapid evidence assessment to really get a better understanding of the evidence and research that existed on GBV and nutrition. And as part of the rapid evidence assessment, we looked at both the direct and indirect pathways of exposure to GBV and nutrition outcomes for children. The indirect pathway, which was the violence against maternal caregivers and what that meant for children's nutritional outcomes. When we looked into that, there was a lot of evidence and a lot of research that had been carried out that really documented strong linkages between intimate partner violence against maternal caregivers and really three categories of childhood nutritional outcomes. The low birth weight, and we found that maternal exposure to intimate partner violence was associated with lower birth weight. We also found that, and the research demonstrated, that women who experience intimate partner violence are less likely to practice exclusive breastfeeding or engage in early initiation of breastfeeding. IPV was also associated with stunting for children under 5, severe and acute malnutrition. So there were a lot of linkages. The direct pathway that we looked at was the GBV exposure for adolescent girls and the impact on their nutritional outcomes. And really, quite unsurprisingly, what we found, sorry, I've just lost my presentation. Just give me 1 second. But for girls, what we found was that
Sinead, we'll share it from our side. So
oh, thank you.
Going.
Thank you. I was trying to do 2 things at once. So much appreciated. So what we found with the adolescent girls was that there was very little information on the impact of their exposure to GBV and the impact on their nutritional outcomes. They were very much invisible within the research. And there were only 12 studies that looked at it, at their nutritional outcomes, and often from higher income countries. And the focus was really on the linkages with obesity, BMI, and only 1 study looked at child marriage and anemia. So it really highlighted that there are significant gaps in the research and our understanding, and we feel that as we will talk through the GBV nutrition research from South Sudan, you'll see how it will add significantly to the research base. Next slide, please. Yeah, and just in terms of like situating this research and this learning regionally, we know that, within the region that we're in, East and Southern Africa, we're seeing more and more food and protection crises. And within the Horn of Africa drought in northern Uganda, Madagascar, Mozambique, and many other locations. And with all of the nutrition and food insecurity, risks of GBV, including sexual violence, exploitation, abuse, all become more acute. For example, what we're seeing in Somalia at the moment are significant increases in the reporting of sexual violence and also intimate partner violence. Similar patterns are also being reported in Kenya, with 60% increases in reporting cases of intimate partner violence in some parts of some of the drought affected areas. So in all of these locations, we're seeing more and more GBV. Some of the information coming out of and the data coming out of Ethiopia is really alarming in terms of the rates of child marriage, 119% increase in some of the drought affected areas, and also increases in FGM. And if you think about that against the backdrop of what we've just talked about in terms of the risks for adolescent girls and their heightened vulnerability to malnutrition, and also the linkages for women who are experiencing IPV, sexual violence, physical violence, and the likelihood that their children may have a lower birth weight, they may not engage in breastfeeding, and also their children are more likely to have or malnutrition and child stunting. And just to also situate this in the context of South Sudan. South Sudan is one of the highest rates of GBV globally. 65% of women have experienced some type of violence in their lifetime, which is twice the global average. And many adolescent girls, over 52%, get married before the age of 18. Next slide, please. Over to you, Marjorie.
All right, thanks so much, Sinead. So basically, Sinead has provided on the GBV risks, and I will be deep diving more on the nutrition side. So all of us know that we are living in a world that is changing. And what we are seeing now is that malnutrition is rapidly increasing, and this is in all its forms. So currently, based on the recent data that we have, global data that is based on the joint malnutrition estimates, we have around 149 million children across the globe. And these are just under 5 years that are stunted. We have 45 million that are what we consider wasting, and 38 million that are overweight. So essentially, we have seen across the globe increasing rates of malnutrition, and that also includes micronutrient deficiency across. And what is literally driving these high rates of malnutrition is just because of globalization. We have seen a lot of changes in terms of the impacts of globalization on the production, but also in terms of the access. We have also issues related to urbanization, where we are seeing loss of livelihoods, people moving more to urban centers, and we have increasing number of people living in informal urban centers as well. The issues of climate change, I think this is very much huge, and especially within our regions where we have had climate-related issues, including drought, flooding as well. And then, of course, the increasing inequalities, humanitarian crises, and I'll just say in general, the health epidemics, which also includes COVID-19. So just a deep dive into our region specifically, that is the next slide. What I will say that what we have seen, even within our region, which covers Eastern and Southern Africa countries. So in totality for UNICEF, we support 21 countries. And within these 21 countries, we are actually seeing increased rates of malnutrition. So for both undernutrition, overweight, as well as micronutrient deficiencies across. Based on the projection that we had in 2021, 2021, we had around 3.9 million children who were severely malnourished across the region. And of course, we have around 28 million children that are being considered stunted. The prevalence of anemia still remains very high across the region, specifically for both the under 5s as well as the pregnant and lactating mothers. And just based on the Global Nutrition Report, just to highlight, yes, we have significant progress that has been made across the various countries, but as of now, we only have 2 countries in our region that are being considered somehow making either significant progress or on track, with, of course, the key leading being Kenya. This is based on the DHS surveys that was just released 2 weeks ago, and as well as some progress that has been made in Zimbabwe. We have a number of countries that we are not even seeing a significant progress. That is Angola, South Africa, Eritrea, and Burundi. And Burundi, surprisingly, almost half of the children are considered stunted. So what is still driving us within our region? We have seen a lot of health epidemics, looking at in terms of the cholera, AWD, we are looking at measles as well. And this is even made further worse because of the low immunization coverage that we are looking at, and as well as, you know, some of the times in terms of the livestock diseases that are actually impacting availability of milk for the children, but also availability for meat products. Again, in terms of the food security, earlier highlighted, it remains of a concern, and specifically like currently focusing on food security within the Horn of Africa, as well as, you know, in parts of the Southern Africa, specifically Angola, Madagascar, Mozambique remains of high concerns. So when you look at in terms of the response, and this is where part of it come in, basically what we are looking at is a more of a systems approach, looking at collaboration between the various sectors. So social protection, child protection sectors, education, working with the health sector, as well as with the WASH sector to be able to provide comprehensive services across the board. And noting that, you know, for nutrition, it really cuts across the various different sectors, and the impact can be made much more greater when we come together and collaborate. And this is where, in terms of our partnerships, our engagement with the GBV becomes very much critical. Next slide. So looking at in terms of just a deep dive on South Sudan, why South Sudan? What we have seen over the past, South Sudan remains one of the countries that have a really high burden of malnutrition, and specifically for both the under 5s as well as pregnant and lactating mothers. But again, in terms of just the overall vulnerability for both food security and nutrition really remains high. And I'm just reflecting on the slide, what you're seeing based on the recent IPC analysis. So this is integrated phase classification analysis that was released at the end of the year. We are seeing that, you know, an increase in the number of counties that are really vulnerable to wasting, high food insecurity, as well as WASH conditions. So currently we are planning with around 22 counties, and this is already an increase from 17 that was projected at the beginning of the year. So what does that tell us? It still tells us, you know, there is a lot of risks related to nutrition in the country, and you can clearly see for the admission trends, this is just a snapshot of the severe acute malnutrition. You can see for the year 2022, we really had a very high admission trend, that is the line in yellow, in red, when you compare it to the previous years. So the vulnerability is still there for both the pregnant mothers and for both the under 5 children, and they need to be addressed in its totality. So that is it from my end. Thanks, and over to you, Sinead.
Thanks. Passing over to Tesfa now to talk through the GBV nutrition study from South Sudan. Over to you, Tesfa.
Thank you. Good morning, colleagues. I would like to come in to give you an overview of South Sudan study. GBV risk mitigation effectiveness. This study, as indicated earlier, is in a collaboration between Ministry of Health, Action Against Hunger, Kenyatta University, Ministry of Gender, and UNICEF. We have collaborated to make this ongoing study currently, which is underway. So we have started this study. What is really different about this study? As you have seen from the global overview, this study is the first of its kind globally because it combines the GBV related outcomes and the key performance indicator for nutrition. What does it mean? In terms of nutrition access or nutrition coverages, usually what we have always as a nutritionist, we are concerned about is awareness about the program, distance from the program, and interface between the community, girls and women, and health workers. It brings this study really as a new evidence. It brings the GBV-related outcomes and key performance indicator to improve the key performance indicators in the program. What did we do so far? We have conducted baseline validation workshop. We have conducted, I will go and show you what is the phase of the program. So far, what we have done is validation of the workshop with partners, the one which I have mentioned earlier in Nairobi, as well as in Juba. So the regional learning workshop was conducted. So what will be coming next? I will show you in the interlinked objectives, the implementation of in-the-line and other evaluation activities are remaining. Next slide, please. So the methodology is the backbone of the study. So I will take you through this methodology. Next slide. So, who is the target group for this study? As we discussed, women are really the main target. Women and girls are the main target of this study. So why we are doing this study, as we highlighted earlier, we have 4 or 5 interrelated objectives. These objectives are very much interrelated. The first one is we wanted to know to assess the level of women and girls' perception of safety and GBV risk in relation to nutrition services. What does it mean? When women are accessing nutrition services, how do they feel? Are they feeling safe, or are they feeling risk when they are coming to nutrition facilities? Then we wanted to, in relation to this one, we wanted to conduct and develop, implement evidence-based package for GBV risk mitigation in a selected sites for nutrition. As you know, maybe in South Sudan, we have more than 1,200 nutrition sites, but we have selected few sites in targeted population areas. So we developed methodology for evidence-based package of GBV risk mitigation intervention. So after this GBV risk mitigation package, what are we going to do? Our objectives are very much interlinked and interrelated. We will implement this risk mitigation intervention. Then the third objective is to evaluate this effectiveness of GBV risk mitigation program on the perception of women and accessibility and utilization of nutrition service among our target groups. Then what we wanted to do is determine, is there any change in nutritional performance indicator, maybe in defaulter or any other performance indicator of nutrition services because of the risk mitigation intervention, which is going to be implemented. The last objective is to assess factors contributing to the lack of nutrition services utilization among non-participating women and girls who are eligible for nutrition services. So so far what we have covered in these objectives on the ground in South Sudan, we have completed the 2 objectives. The first one, we have conducted the baseline study. The baseline we have generated, that's what we are going to share with you. Then now we are under the process of developing the evidence-based GBV risk mitigation. So what will continue is once this GBV risk mitigation intervention is implemented, we are going to evaluate, we are going to determine the change, and we are going to assess the factors contributing. Next slide. So we have our hypothesis why we are doing this. By implementing this GBV risk mitigation program, we wanted to know whether there is better access and utilization of nutrition services. This is our hypothesis. Whether this ultimately the result of the improved nutrition outcome is because of GBV risk mitigation activity or not. This is our hypothesis, and we have 3 research questions. The first one is whether GBV risk mitigation intervention improves or increase the girls' perception of safety when accessing nutrition facilities. The second question is that this risk mitigation intervention affect women's and girls' use of nutrition facilities or nutrition services. So the third question is, after implementing this one, GBV risk mitigation actions, whether we are going to improve performance of nutrition services as compared to other facilities, because we are doing it in selected facilities and we can compare the facilities. Next slide. So what is really the approach of this study? As presented, highlighted earlier, we are conducting formative research and testing tools, and we have conducted baseline data, and then we will really implement the intervention, GBV risk intervention, based on the baseline data. The intervention is going to be designed based on the baseline data, generated key findings, and adapt this finding
I think we lost Testafe. Are others hearing him? If you could put in the chat, if you...
No, I can't hear him.
Okay. We might, Testafe we've lost connection with, so maybe his colleague, either Martin or Sinead? Or...
Sure. I will jump in until Tessa comes back. Yeah, so in terms of the approach, it's formative research. We've done the baseline data collection. It was carried out in September last year. And we have comparison and control sites, which we'll talk through in a minute. The baseline was conducted. We are in the implementation phase, and then we will do the end line at the end of in September, this coming September. Next slide, please. Whoops, sorry, 1 second. Yeah, just in terms of like a very quick run through of the activities, we did like a design workshop in February last year to really test the measurement tools based on a pre and post test that was carried out in collaboration with Harvard University or Harvard Humanitarian Initiative in 2021. And then we finalized the tools and the approach and got the research protocol and the ethics approval, and then did the baseline data collection in August 2022, and then safety audits in the nutrition sites. And we'll talk a little bit more about those during the implementation package. And now we've done the preliminary analysis late last year, and that was also involving a validation workshop in Juba with the government and with other partners. And we are currently in the implementation stage, where we're implementing a package of services, or a GBV risk mitigation package that I'll talk through in a little while. And then we will do the end line in July, August 2023. So everything will be completed by September this year. Next slide, please. In terms of location, is in Warrap State. The location where we're piloting the GBV risk mitigation implement our interventions is in Goriel West, and there are 5 sites that are supported by ACF, and the control sites are in Goriel East, and there are 2 sites. Next slide, please. Great. In terms of methodology and data collection, I'm not going to go into too much detail on this, but the design is quasi-experimental with a focus on the pre and post test, and it's a mixed method. So looking at the quantitative and qualitative data. The study participants are selected from beneficiaries, women and girls and children who use stabilization sites, outpatient therapeutic program, and those who are in the TSFP. It includes children under 5 and pregnant and lactating women, including girls below the age of 18 if they have children. Data collection was random sampling, and we used a variety of different methods to collect data. This included questionnaires using ODK, and we had 922 beneficiaries who responded to these detailed questionnaires. And then we also had 14 nutrition staff. So that provided the quantitative data. We then conducted in each of the sites focus group discussions, 4 of them, and key informant interviews with staff and various beneficiaries in each location. And we had quite a large team, and this was all conducted in collaboration with Kenyatta University, who supported the research. Next slide, please. I'm going to pass over now to Martin to talk through the findings. Thank you.
Thanks, Sinead. Before Martin comes in, I just want to highlight a few methodological things. For sure, there will be a question from participants. Of course, as any study, we have the limitation of this study. One is it's not kind of multi-sectoral, it's only focusing on nutrition area. The second one is more of health facility based because there are a lot of nutrition facilities, as I mentioned earlier, 1,200 facilities, and we cannot really do it in every facility. So we have limited this study in selected health facilities, but in the future we can scale up in collaboration with partners. Over to you, Martin.
Thank you so much, Tesfa and Sinead, for taking us, and also Marjorie for taking us through the background of why we needed to do the study, the context of the Horn of Africa with the conflicts and the drought situation, and narrowing down to South Sudan being a key resource country for any GBV work. So please allow me to take you through the findings of the baseline study. And as Tesfa mentioned earlier, our focus was mainly on the objective 1, and I'll be taking you through the levels of key demographic characteristics, the levels of perceptions of safety, and also some little bit of maternal, infant, and young child nutrition findings. So you find that the population is generally young, between the ages of 20 to 29, and majority, the education level of the participants was quite low at it's only 87.7 respondents had received any education at all. And you find that we found that 21.7% were responsible for the primary income of their household. So you find the household level, the household head, they had low education level, and they were a majority were able to support their households. Monogamy is quite high in the community assessed. And we found that those living in polygamous households mostly are two wives. By the nature of the cultural context, polygamy is allowed, and by the mere fact that as much as one household is added technically, you find that most of the households were led by women, because you'll find roughly one man marrying two to three wives. So that's why I say it is technically led by women. And majority of those married got married between the ages of 15 to 19. And 3.4% of the respondents were widowed. And in South Sudan is prone to flooding, and so during the data collection period, about 21% were displaced by flood, conflicts, and drought. And findings, we were able to do some community safety audits and for FTGs. And it shows that the early and forced marriages have reduced in the communities compared to the previous area. And I'll shift over to the perceptions of safety that we were able to analyze. So over to the next slide. Yeah, so almost 98% of the beneficiaries access the nutrition sites by walking. This is because public transport is not affordable to many beneficiaries, and the cost of public transport, such as the motorbikes, doubles during the rainy seasons. This was from the focus group discussions. And of these 98%, 14.5 felt unsafe during the journey, while 4% expressed concern at the nutrition site. So it shows that as much as we may think that our beneficiaries are safe in our nutrition sites, 4% is it's not that little. And more than a third reported they had a concern of physical violence on their way to the nutrition site. So this included mainly attacks by bandits, or animals, the baboons. So this was something that it was also noted. In terms of perceptions of physical and sexual violence, majority, remember very well, Shani, that highlighted 60% have ever experienced, women have ever experienced physical and sexual violence. And this figure now is higher in our study site, because 88.2 had no concern for physical violence at the nutrition sites. This is good. However, 11.8% reported they had a concern. So as I highlighted earlier, we may think that our nutrition sites are okay, but our beneficiaries are saying that they are expressing concerns. In terms of women, 10.6 of women accessing the nutrition services expressed varying magnitudes for sexual violence on their way to the nutrition site. So, we had women expressing negative perceptions in terms of having been fearfully attacked during or on their way to accessing the nutrition services. But during the focus group discussions, it really came out quite clear that some cases are underreported due to stigma. So a beneficiary or a mother, a woman who might be attacked from a nutrition site and go unnoticed. So in terms of the perception of intimate partner violence, 5% of women and rather 5% among married women reported medium to very high level of concern about violence by an intimate partner because of accessing the nutrition services. So during the community safety audits, they expressed that some men don't allow their women to to visit those nutrition sites because they will come back very late And if they come back very late, they'll not have someone to prepare food for them. So that forms the basis to promote the wife beating. And other times, people at the community perceive the time taken at the nutrition sites to be quite high. I mean, to be quite long. So that's why they prevent their wives from accessing the nutrition sites. And among the married women, 5.8% had medium, high, or very high concern for IPV. And domestic violence and intimate partner violence was seen as the primary GBV risk for women and girls in the community. So you ask ourselves, is it our services, are they forming the basis for the sexual violence or physical violence? Yeah, so something to ponder along as we move on to the next slide. Next slide. Thank you. So in terms of we had an objective looking at the factors contributing, factors related to perception of safety, and displacement status was one of the key issues that were highlighted, and it had a significant relationship with the perception of safety, because displaced respondents are more likely to report feeling unsafe while accessing the nutrition services, while having a disability had a negative relationship with the perception of safety. Persons living with disabilities were more likely to report feeling unsafe while accessing nutrition services, and the long time or distance taken to access the nutrition sites increased the possibilities of bandits attacking and on the road, making women and girls feel unsafe, and also aged, so adolescent girls, including young girls, were more likely to report feeling unsafe. And findings from the FDGs showed that some adolescents may fear accessing the nutrition sites because they fear, because most of those pregnancies were unwanted or unintended, hence they shy away from accessing the nutrition sites. While at the nutrition sites, it was found that the presence of toilets segregated by gender, being lockable from the inside and having a roof were found to make women feel safer, while overcrowding at the nutrition site also were found to make women feel more unsafe. But the presence of GBV referral mechanisms made women feel safe and were able to report cases while accessing the nutrition sites. In addition, negative reactions from spouses or family members discouraged women from accessing the nutrition sites. So what do women do? How do they reduce the risks? 45% travel in groups, while 29% are accompanied by their neighbors. Although some partly reported spouses, but findings from the focus group discussions showed that at times it is not happening because of the culture, and because they mentioned that culture doesn't allow a man to accompany his wife to such places. They believe that if you accompany your wife to such places, you are you are regarded negatively. So these are some of the key things that were highlighted. And something very unique is the structural changes at the nutrition site, including employment of more female staffs, made beneficiaries to feel more safe. Over to the next slide that focuses on the nutrition services at the nutrition sites that we surveyed. Over to the next slide. Thank you so much. And the ability to access nutrition services needed correlates positively with perception. And of those, that 57.5% of those who could access the services when needed felt they were either safe or very safe. About 1.8 of beneficiaries were forced to sell therapeutic food that given at nutrition facilities, and 56.3% of those of the beneficiaries that were selling therapeutic food reported to be forced by husbands, while 2.7 shared the therapeutic food among its siblings, while 4% skipped meals as a coping mechanism. However, The utilization of services has shown to improve the relationship between the nutrition staff or the nutrition staff or the healthcare workers supporting the facility, and also the community and household members. So there's a good positive relationship between the nutrition staff and the community members. Next slide, please. That focuses on the maternal, infant, and young child nutrition. And we're able to pick some key indicators, including exclusive breastfeeding, where 80% of women initiate breastfeeding. However, 47% are exclusively breastfed. And one of the key determinants that were found to be positively correlated to breastfeeding is support by husbands. Husbands who support their wives, and very high educational level of the mother, and households that had a very high household income had a positive, significant relationship with exclusive breastfeeding. And we were also able to access the minimum dietary diversity, while it is only partly 45% of women achieved the minimum dietary diversity. And also, surprisingly, key determinants included the support by husbands, and very high education level of the mother, and household income also had a positive, significant relationship. And in terms of male support, we found out that pregnant women who are supported by their husbands to eat a variety of diverse diet, attend antenatal care, and rest during pregnancy, and also exclusive breastfeeding was quite high. So this is an eye opener to more of seek out male engagement in our nutrition programs. Next. Yeah, so that's it for the findings. I will pass it over to Shanit to take us through the intervention. So we've seen the baseline. And so the question is, what next? What are some of these RM risk mitigation interventions that we are going to take through? So Shanit, over to you, and thank you.
Thank you, Martin. Next slide, please. So yeah, Martin, I think that was a great question. What next? We know what the issues are. How do we address them? So we've developed a theory of change, and really the theory of change and the GBV nutrition programmatic implementation package is really meant to address these issues. This is in very small print, so I understand you might not be able to see it, but we will circulate it after. But just very briefly, to the left-hand side in the pink, you'll see the risks, and they vary from like lack of information on services or staff not trained, could be the physical layout of the nutrition sites, or the services not being provided in a safer, accessible way, either because of the location or the distance or overcrowding. Then you see the orange column, and that's really, the types of GBV affecting women and girls. It could be GBV they're experiencing on the way to the nutrition facilities, in the nutrition facilities, at home, negative coping mechanisms. So the different manifestations. Then in the green, and that's what we're going to talk about for the next few minutes, is the GBV risk mitigation activities. So really, what we can do to address the risks and make facilities safer for women and girls. So everything from conducting safety audits to community consultations, to having female staff at the facilities, to making sure that those staff are trained on GBV and how to deal with disclosures and make safe referrals. And then our community outreach, and as well as any of the structural or service delivery changes that we make based on the risks identified. At the very bottom, you'll see a brown box, and that's the risk mitigation strategies that women and girls may adopt. It could be anything from traveling in groups or getting someone to accompany them, or using safer routes. So all of the things that Martin talked through that were identified during the baseline assessment as risk mitigation strategies. And then on the right-hand side, you'll see the outcomes in yellow. So if we implement these activities, what is it that we want to see? And what is it that we hope to see by the end line? And basically it is that GBV risks are reduced, women and girls' perception of safety at the facilities increases. They feel safer on the way there when they're at the facilities. And that the services and the way they are provided are safer, which will ultimately increase the utilization of these services. The impact, it's on the right-hand side as well at the bottom there. It's in purple, and that's, you know, overall, what do we want to see? And that is women and girls are safe and that nutrition outcomes improve for them and their children. So that's a quick snapshot of the theory of change and the implementation package. Next slide, please. I'm not going to go through these in detail, but as I mentioned, you know, these are some of the GBV risk mitigation measures that are currently being implemented in South Sudan by ACF to address the risks that were identified during the baseline assessment. So some of the measures include conducting regular safety audits and implementing site-specific changes. These can either be linked to structural changes at the facilities, so the lightings, the latrines, separate facilities, locks on latrines, reducing overcrowding, having separate areas for male caregivers. But it also can include changes in service delivery based on the issues and the concerns raised. So the timing of the services, the wait times, having more nutrition services and outreach sessions to potentially reduce the likelihood that women and girls have to travel as much. And also making sure that there's some additional support and services for women who come with their children, to make it more likely that they use the facilities. Next slide, please. The other area, and I touched on it already, is just staffing, making sure that we are hiring more female staff, because that's what women said made them feel safer. And then when we are hiring staff, male and female, ensuring that they're also trained on GBV, how to deal with disclosures, how to make referrals, and that, you know, they're able to support anyone that comes forward and help them access services. And again, making sure also that we have adequate systems in place to protect against sexual exploitation and abuse, and that staff and beneficiaries know how and where to report and where to seek help. Next slide, please. The other component is around consultations with women and girls, like continually engaging with them and finding out, you know, what their concerns are, what the risks are, and making sure that they're involved in the design and implementation of any risk mitigation measures. You know, within some of the measures that are planned and currently being implemented include having GBV focal points within ACF and hiring additional staff so that they can discuss and have more direct engagement with women so they feel safe sharing. The other area is around making sure that community-based feedback mechanisms are available, are trusted and work, and that there is actually a feedback loop whenever concerns are raised by either, you know, the broader community or women and girls themselves. So we're constantly improving the services. Next slide, please. And a really, really important and critical component is strengthening referrals. So identifying and developing relationships with GBV service providers. So nutrition service providers communicating much more with the GBV service provider, understanding the referral pathways, knowing how and where to refer. and really creating these linkages in each of the locations and making sure that, you know, you're engaging with the GBV service provider so that we're training nutrition staff on how to deal with disclosures, but also, you know, on the other side, that we're also training GBV service providers how to identify malnutrition and refer to nutrition facilities. And setting up procedures and protocols for these referrals so that we can keep track of them and that we coordinate between GBV and nutrition service providers. Next slide, please. The community awareness, you know, nutrition staff and nutrition community outreach workers have a lot of coverage. So making sure that they are trained on GBV services and key messages so that they can include that in their nutrition outreach. And that they're also working to tailor messages to address some of the harmful gender norms. You know, some of the findings in South Sudan were that men couldn't accompany women to nutrition or to collect firewood because they would be viewed poorly by other men in the community, and really trying to encourage more social and behavioral change around male involvement in looking after children and supporting their wives. And obviously this is a longer term component. We're also looking to engage the community leaders so that they're really providing some additional awareness raising and support to try and change norms around gender inequality, and also supporting women and girls to access nutrition services and overcome some of the barriers that might prevent women from accessing it. But there's a lot that can be done, and a lot that is very much being adapted to the context in South Sudan in terms of behavior change and trying to identify and address specific norms that are impacting access to nutrition services as well as GBV. Next slide, please. So as I mentioned already, you know, we've done the baseline, and we're in the process of the implementation of the intervention. So that package, GBV risk mitigation package that I just touched on, so it will be ongoing until June 2023. And then we will initiate the end-line data collection following the same methodology and approach that was used during the baseline. So hopefully, you know, by the end of this year, we will have some really concrete results about what's working and how to adapt and scale it up in other locations. Next slide, please. And finally, over to Marjorie to discuss a little bit more about the next steps and going forward.
Yeah, thanks so much, Sinead, and colleagues for bringing into light what we have learned and the experiences that we've had in South Sudan. Now, looking forward, we have a number of proposals, and basically for us, key is to enhance the general understanding on the GBV and nutrition. We note that this is the first kind of research that we have done. It's much more of implementation research. We have a lot of learnings that we have gained from the study. A lot of recommendations that have come in. We have identified a number of opportunities as well as the gaps within the current programming. And basically what we are looking forward is much more in terms of enhancing that understanding and looking at what can we be able to do together to address both the women's nutrition, adolescents, girls' nutrition, but as well as also address other issues related to malnutrition in totality. Currently, we have the Global Nutrition Cluster annual meeting that is ongoing. We had the meeting started last week. We have a number of side events that have been going on yesterday and today. And basically for this meeting is also just to bring visibility yes, to the nutrition elements, the progress that has been made, but also we provide an opportunity to integrate and just share some of the learnings from the ongoing research, and looking at also in terms of identifying the opportunities where we can be able to accelerate the work. We are very much working very closely with the Global Nutrition Cluster. We usually have what we call the Technical Alliance, and under the Gender GBV work stream, one of the key things has been to engage and identify some of the opportunities learning as well. And we are hoping for the countries that will be showing interest in terms of scaling up the GBV as well as nutrition integration. We have resources available at the Global Technical Alliance team through the Gender and GBV work stream, but also at the regional level, we can always be able to engage and look at how we can be able to accelerate, identify the opportunities, and ensure that whatever programming elements that we have identified as part of our programming can be implemented at the country level. And then just lastly, some of the key things that we are looking forward to, we really want to create an appetite within the SRO region. So within the 21 countries and beyond. So we look at what can we be able to do together. We already started engaging at the regional level with the countries in the Horn of Africa, because we note that GBV risks are really increasing as part of the vulnerabilities to nutrition, but also as part of the overall vulnerabilities towards addressing some of the critical issues. So we have had collaboration and engagement with Ethiopia, Somalia, and Kenya, and currently also discussions with Mozambique to look at in terms of integration of GBV and nutrition as part of the overall response. And again, one of the key things, we have just developed a nutrition programming package, and I see very many comments online that we can use, that we can incorporate in as part of the programming package. And we are hoping that for the other countries, the other sectors as well, that have interest in terms of advocating and integrating for GBV and nutrition can be able to adapt. And of course, this can be assisted in terms of the overall implementation, but also we can have promote cross-learning across the various countries. So of course, we are looking forward. This is the start. As Martin had said, of course, we are learning from it. We want to expand it just beyond just GBV and nutrition. We are looking forward to having other sectors as well implementing, because we know that the issues of GBV, the issues of nutrition are really cross-cutting, and we will be looking forward to enhancing our collaboration, enhancing our partnerships, and enhancing the scale of the service provision. Thanks, and over to you, Jessica.
Great. Thank you, Marjorie. I just closed the chat for questions because we do now have quite a few, and I want to make sure in our last 15 minutes of our webinar today that we do have an opportunity to answer those that have already been posed. So please note, if you do write your questions in the chat right now, we might not get to them because we do have a whole list of others as well. But if you want to just keep giving information in the chat, you can, but sorry, we might not be able to get to them. So coming into some of our speakers, I'm going to start with Sinead. I have a couple that are specific to the GBV side of things, and then I'll turn it over to the nutrition side. So Sinead, we had colleagues from South Sudan, from the GBV AOR there. They mentioned 2 additional linkages that maybe didn't come out in this presentation, but maybe something to think about in terms of also reducing or mitigating GBV risks. One was around the point of decreased productivity within the household in terms of women who carry a large burden of household level chores and food consumption. And so this can also lead, when we have high levels of domestic violence particularly, it can lead to lower levels of or decreased productivity, which then also leads to decreases in food consumption and then leading to nutritional outcomes. So the question is if you had run across any of that. And the second linkage that was also mentioned was, did you also think about the safety of the caregivers? I noticed that there was a 39% concern of physical violence on the way to nutrition sites, but was there specific thoughts around safety of the caregiver in particular? So those are two linkages. And I'll turn over to you, Sinead, for some very brief kind of feedback on those.
Sure, and I will be very brief because I want to leave time for more questions. On the safety of caregivers, we mean the mothers who were coming with their children to the nutrition facilities. So yes, it was identified as a risk for violence on the way or in the home. So, you know, certain mitigation measures, including the timing of the nutrition services and trying to have more nutrition services through outreach, have been introduced as some mitigation measures. But then there's also risk reduction strategies that women themselves engage in, like accompaniment or moving in groups. So I hope that that answers that question a little bit.
Mm-hmm. Yes. And I think it was also an addendum if you wanted to add more to your slides from that participant, Fanta. And then we had a question from Patrick around cash and voucher assistance. In their programming, they've been looking at cash and voucher and nutrition. Do you think that cash and voucher could be an asset in linking GBV risk mitigation and nutrition? Is there a way to utilize that that would then decrease the risks of GBV?
Let me come in. This is Tasfa speaking.
Great, Tasfa, go ahead.
Thank you. Previously, just there was a question linked in terms of nutrition status of women and beyond reducing the GBV risk for targeted women and girls. Yes, definitely. We have since we have conducted the baseline, we have seen that the women dietary diversity issue in the baseline. So now after implementing the mitigation package or the risk mitigation package, the risk reduction package, what we are hoping that at the end line is women nutrition status is improved because households are sensitized, where women we are also given opportunity in terms of nutritional values in terms of dietary diversity. The other part is, yes, in so many countries, cash and nutrition status are being linked. The result is really mixed, as you all know. So basically, one of the area which it can really contribute in this cash, if we integrate cash component, is if we really target pregnant and lactating women to ensure that, as you have seen from the baseline, there is a low data diversity. This is a concern worldwide, everywhere. So it can really be useful if we can really use cash modality to really improve the nutritional status of women and girls, as well as for children. Over to you, Christine.
Thank you. Thanks, Sesave. And then we had, and I think this will be a good reinforcement, because you did mention the need to have all nutrition personnel know about the referral pathway. Mirko had asked specifically about if you're collaborating with police, but I'm going to expand that question, and maybe you can just remind us, because this is such an important part of these linkages with other sectors. Can you remind us of the steps you took to ensure that nutrition actors understood and then could also refer to other services, and how those service providers understood the services that you were providing as well? So either ACF or UNICEF. I don't know who wants to take that one. Maybe Sinead, if you want to start. Sure.
And please, Tessa, you're much more familiar with the sites, so jump in whenever. In the locations, we've GBV partners, TOSH and EIRD, well, TOSH for this part of it. So we have trainings and linkages directly between the nutrition staff in these locations and the GBV staff. So there's a lot of kind of cross-learning and referrals through that, and also kind of regular coordination and meetings to understand, you know, and also make sure that referrals are actually happening on both sides. And once it goes to, and this is to respond to the issue around the police, you know, nutrition staff are not GBV specialists. So whenever it comes to, you know, being able to provide more comprehensive information on referral options, the GBV service provider is generally better placed to provide these detailed information and case management for survivors who need assistance. So the referral would be to the GBV service provider in the location of the study. Tess, I don't know if you want to add anything to that I haven't covered.
Thanks, Sinead. Basically, when this study is really designed during the Inception workshop in February 2012, local partners who are really expert on this GBV referral and linkage, who are currently operating in those locations, were identified. Mapping of partners so that, you know, nutrition partners at the cluster level, at national level, also at state level, were sensitized and trained. We have done several virtual trainings and also some integration of nutrition and GBV modality in the community health workers and different levels. So the responsibility is non-nutrition partners, but they closely work with the GBV partners so that whenever there is a case, the referral mechanism will be in coordination with local partners who are really operating in the area, working and implementing GBV activities. Over to you.
Great, thank you to you both. And if you're interested as a nutrition partner to learn more about how you can mitigate risks, you can go, the GBV AOR on behalf of its partners has published the interagency guidelines for each of the sectors that work in humanitarian settings. And you can find more of these key tips that were just mentioned by both Sinead and Tesfa. I have a question. I'm going to come back to our ACF colleagues because these are really about the study. There were quite a few questions around gender, and I'm going to group these together. So a few of them had mentioned it would have been interesting to see the difference between women-led households and men-led households in terms of these outcomes that were discussed. So that's one. The second was wondering, you mentioned very strongly that husbands were a big factor in terms of the adoption of good practices, but they noticed that the attendance at the ANCs was still low. So maybe if you could talk a little bit about those dynamics. And then lastly, both genders accessing nutrition services, do you have evidence that looks at directly the disproportionality that GBV is affecting girl children more than boy children, for instance? Our assumption, and we do have evidence in other more general senses in terms of the disproportionality of women and girls being most affected by GBV, but specifically in nutrition when we talk about male children. And then we also said caregivers as well, but I think later on in your presentation, you did mention that. So those are some of our issues around gender. So one is the issue of, was there any sense of looking at female-headed households versus male-headed households? You mentioned good practice in terms of that if husbands were encouraging wives, they tended to adopt better practices, but we still saw attendance was low for antenatal care. And then looking at GBV in terms of, or nutrition outcomes as well, boy children and girl children. Over to ACF. Maybe Tesfaye, if you want to start.
Okay, thank you so much. Basically, you know, currently what we have done is a baseline, and what we wanted to do is implement a risk mitigation package and see if there is any difference between, as you mentioned, gender differences, and also in terms of nutritional outcomes, and also basically for the nutrition facility access for women and girls. So basically what we can speak about this variable will be after implementing the risk reduction mitigation, then we'll see at the end line. It's better, I suggest in my opinion, to talk about whether there is a difference. The data is there, we are collecting the data, but comparing the baseline with the end line will be a perfect approach to really respond for this specific question. Over to you.
Okay, thank you. We had a grouping of questions around people living with disabilities and their ability to access nutritional facilities, particularly what are the challenges and how are you addressing those? And then it was within the same, another one of our colleagues had asked if you saw an increase in vulnerabilities among the disabled. Tesfaye, I think, or Martin? So this is specifically for people living with disabilities and whether you made specific considerations for those with disabilities within the study. Since we know within the GBV community that they are much higher risk of gender-based violence generally, and it's known probably around 25% increased risk among survivors with disabilities. Any response or how about ICF? Tesfaye? Or Sinead?
Basically, it's one of the concerns we have been discussing in the inception period to collect what is really the variables of our interest in this study. Yes, disability is one of the key variables, and as you know, also in South Sudan, the Food Security and Nutrition Survey, which is jointly done by UNICEF, FAO, and is collecting this data. So we were thinking of maybe for referring different researches and different secondary data on top of what we can really cover as a variable. Basically, we need to look into this to really respond to this specific question and link and review the specific variables. So far, it is not analyzed as far as I know, the FSNMS data for disability, but one of the interesting area which we can really analyze and link with this study. Yes, of course, it is a concern, but it's very early to speak about the disability component of the GBV risk mitigation. Over to you.
Okay. But it sounds like, Tesfaye, you are collecting the information. You just aren't in a position to be able to analyze it at this time. Is that accurate?
Basically, in this study, the information is very limited, what we are collecting, but there is ongoing data collection mechanism within the country, FSNMS, they collect on the disability component. So due to the time for analysis, we can really work with the team in the country to analyze this component, but this is not the specific area of this study in terms of disability focus. Okay,
well noted, and maybe a good point to take away from this on your side is too, there's a lot of interest around that. We only have about 2 minutes left, so I will close with some of our last comments from our participants. And Frederica, I think you made a really good point in terms of some of the obstacles in implementing nutrition programming that takes into account GBV. And that's nutrition is often seen as a medical intervention, but we don't always look at these social causes. And that's many times where we're able to look at some of the risks and vulnerabilities that we see at household level that really do impact the safety and security of women and girls. So that's well noted. And then we had another participant comment on, and I think this is in the same vein, that we focus a lot on the treatment and not always on the prevention. And I think this is also when prevention is many times looking at some of these social elements that we talk about, risk factors for GBV as well. And then lastly, we had Susan who said one of potential ways to mitigate some of these social issues is looking at the male change agent approach, which they have found success in their programming. So I'll end here with our questions. We did have others that I did see, and I'm sorry we didn't have enough time, but that's just, I think, also an indication of all the interest around this. So thank you all for joining us. We were really pleased to see so many of our GBV colleagues and then also nutrition colleagues on the line. And I think you could see in the chat, it really brought a depth of discussions that we don't always have. So more of a holistic view, which is really much appreciated. If you are interested, sorry, Martin, we didn't do your mentee. So Martin, why don't you, we do have a mentee. If you want to, in the chat, you'll have to, Martin has put in the link to the mentee, which is in your chat, and you'll have to open a new window, and then there'll be some questions that he will ask that will kind of bring the whole webinar together. So while that's the voting code, that's even more important. So if you put the link to the mentee and then put in the code, we'll be able to see some of your last sort of summary of thoughts. And while you are doing that, if you are interested in joining, we have some new people. If you're interested and you're doing GBV work at the regional level, and you're interested in joining the Regional GBV Working Group of East and Southern Africa, please reach out to my colleague, Christine Cabelle. And Christine, if you could put your email in the chat. And so, and then you can also reach out to the food security nutrition working group if you're a regional nutrition actor who's interested in learning about those food security nutrition at the regional level. I want to thank Brenda and Charity for both joining us and for co-hosting this event today. Please keep in mind that we will also, at the Regional GBV Working Group for East and Southern Africa, we have another emerging practice webinar next week. We usually hold them once a month, but we're benefiting from all of the things that recently were published. We will have another emerging practice for all of our colleagues on the line, and that will focus on the intersection between women and girls safe spaces and one-stop centers. And so we have a lot of good analysis now. We're finding that in many emergencies, we have partners who are equating the two, which is not the reality. So if you would like to learn more about one-stop centers and how they link to women and girls safe spaces, please do join us next week. If you're not currently on our mailing list, you can contact Christine Cabelle directly if you'd like to be on the Regional GBV working mailing list. And then I also see we have some email addresses as well. So please do reach out directly to Christine Cabelle because she won't be able to track all of these. And then you can see if you're interested in joining the Food Security Nutrition Working Group, you can join there. There's the link that Brenda put on, but please note that you have to contact them. So they're not going to be furiously writing down your emails. As mentioned throughout the presentation, we will be sharing the presentation. We will also be sharing all of the reports that were mentioned, particularly the one, many of you wanted to see the one from Marjorie, and there are a few others that will be shared. We do have your email addresses from the registration, so please note that. This is being recorded. So the recording of this webinar can be found on the GBV AOR's YouTube channel. So you just have to put, if you go to YouTube and look at GBV AOR. So Martin, why don't I turn it over to you for the very last comments, because it looks like we have a great word mapping here.
Thank you so much, Jessica. I see it's building up. I see the center of it all is informative. We have GBV at the center of it all. We have quite numbers. We have fun, we had IPV, We have prevention. There's also engaging women. Wow, it has already changed. Interesting, engaging, inspiring. Wow. I can also see planning with GBV lens and male caregivers. So this is quite good, quite insightful. Thank you for participating in the Menti. I see it's not changing a lot. We have GBV is an important issue, and also coordination. I think that's it, Jesse.
Great, thank you.
Yeah, awesome. Thank you so much. Over.
All right, thanks everybody for joining us. As we mentioned, if you would like to link up with our co-organizers today, that is the Regional Food Security and Nutrition Working Group or the Regional GBV Working Group, please do reach out through the links or the email that we provided. And yes, our one-stop center and Regional GBV work and Women and Girls Safe Spaces is actually being moderated through our GBV community. It will be posted on the community practice as well. So thank you all very much for joining us. I do hope we see many of you next week for our next emerging practice webinar, which again will be in the afternoon next week. We'll send out invitations shortly. So thanks everybody. And thank you all to UNICEF and ACF for your great presentations today. Thank you.
Thanks, Jessica. Have a great day.
Thank you, Jessica.
Thank you.